Advanced implantology is still a different specialty, but your basic implantology should be and is part of your dental practice. This is the one which actually raises your practice. This is a practice builder. Whenever the patient comes, when we started our implantology way back, 20 years back, patient didn't know what the implant was. We used to tell them that there is something called as a dental implant to replace a tooth. But nowadays, patients come and ask for implants. They are so aware, maybe because of the media, maybe because of the number of implant companies now available. So it is part of your, like your crowns, like your root canals, even a simple dental implant is part of your general practice. So, so first and foremost, when the patient comes to you, he has a chief complaint. Always listen to the chief complaint and then make out what is his requirement. His chief complaint will tell you what his requirement is, whether he's more towards aesthetics or more towards functional. So functional means he'll say, I'm not able to chew food. Khana nahi kha sakta main. Okay, difficulty in chewing food. Whereas aesthetics is, you'll come across patients who will say, sirf aage ke laga do, piche ke rehne. Obviously, you'll be doing a sin doing that. We'll discuss about that. Never ever replace only the front ones. So, listening to patient's chief complaint, you can make out what his expectations are, okay, whether it's functional or aesthetics. Then, of course, a detailed case history. By detailed case history, again, we'll discuss what are the indications of implant. You can replace a single tooth, you can replace a multiple teeth, you can replace the full arch, you can also replace full mouth, both upper and lower arch, and you can also place implants to replace the lost nose. Small time, I'll just discuss a case of replacing the nose also. Okay, so these are the indications. Not so important. We all know what is more important is where not to place the implant. Contraindications. Somebody asked, what is implantology? I said, knowing or having the knowledge of where not to place the implant is implantology. So that you don't make a blunder, you don't end up in a disaster. Okay? So first and foremost is acute infection in the vicinity. This is not an absolute contraindication, it's a relative contraindication. Relative contraindication means we can manipulate, we can alter our treatment plan, we can alter start some medication and still do the procedure. So it's a relative contraindication. Long back, when it's around Abhishek, it was around 10 years back, we had done a study which was published in one of the international journals, where the selection criteria of the implant cases was infected teeth. So the tooth had to be infected. That was the selection criteria. So we selected 30 cases, all infected, extracted the teeth, prepared the site and placed the implant with 94 or 95% success. Okay, 94 or 95% is an acceptable success rate. 5 to 7% failure, even the companies or almost all the implant big wigs also say they have around 5 to 7% of failure rate. So it is again a relative contraindication, it is not an absolute contraindication. Second comes inadequate quantum of bone. The quantity of bone, if it is sufficient, of course, with the same condition you cannot place an implant, but you can augment the bone. Inappropriate quality of bone, how to manipulate during your osteotomy procedure, again we will discuss. Okay. With the existing soft bone, you can manipulate, you can alter your osteotomy series and then place the implant. Then uncontrolled systemic diseases, of course it's a contraindication until the disease is under control. Then bone metabolic disorders, something like bone metabolic disorders. Osteoporosis. Is osteoporosis a contraindication in itself? You may have, if your bone turnover is slow. What is osteoporosis? The bone turnover is slow. The rate of osteoclastic activity is high. The osteoplastic activity. I mean, there is a difference between osteoplastic, no balance between osteoplastic and osteoclastic activity. But you can still place a implant, leave it for a longer time. If not 4 months, leave it for 8 months, 9 months, you can still do it. But people, the patient, osteoporotic patients who are on bisphosphonate therapy are an absolute contraindication. Why? What does the bisphosphonate do? It reduces the osteoclastic activity. Now just recall your signaling theory in bone formation. What does osteoclast do? They signal that they are resorbing the bone, that signaling effect goes to or starts the osteoclastic activity. So now when we reduce the osteoclastic activity, when the patient is on bisphosphonates, in turn what happens is the bone turnover is also stopped. So will the osteointegration of the implant occur? No. That is why, plus when we have created a trauma to that during the osteotomy procedure, the surrounding bone will also undergo necrosis. So it is not the implant will fail. The whole bone around that area, the whole chunk will be separated from your native bone, the healthy bone, and it will be separated. Again, it's a disaster. So that's an absolute contraindication. The newer studies do say that oral bisphosphonates, people still can undergo implant therapy, but patients on IV bisphosphonates are absolute contraindication. But still, never take a risk because it is still under studies. It is not confirmed yet. Then pharmacological agents affecting bone turnover, psychiatric illness. Is it a contraindication? Yes, but not because of any procedural. It is because these patients cannot take care of their oral health. That is why it is a contraindication. Poor motivation and maintenance compliance. I'll show you a case. Poor motivation. Unattainable prosthetic rehabilitation. Whatever patient desires, if you're not able to provide that, why place it? So again a contraindication. So your chief complaint done, history, examination, investigation in detail. First step in clinical examination is edentulous space assessment. Whenever there is a need, whenever the patient comes to you with missing teeth or teeth to be extracted. So you have to assess. First make a model, draw what you want to replace and check the size of your implant, check the size of the prosthesis, everything. This is how you can do it. So you have to assess how many implants in that edentulous alveolar ridge and what will be the size. We'll come to that in detail. And also, the thing which is mostly missed is the bite. You don't ask the patient to bite and see how is the opposing arch. Let's say, if the teeth have been missing for a longer period, what will happen to the opposite arch? It will supraerupt. It will engage the space of the opposite arch. So will the implant placement still will be possible. But what happens in the second stage is you're not able to give a decent size or required size or the height of the prosthetic tooth. Okay. So ask the patient to bite or prepare a master cast and then a study model and then see what is the vertical height or clearance available between the opposite tooth and the crest of the alveolus. Best is to prepare a wax up. This wax up you can also use it as a guide while preparing the osteotomy. Understood? Any doubts, please raise your hand and we'll discuss. Okay? Any doubts in between? And believe me, the more we discuss, more we learn. Otherwise, after some time, I'll see half of you sleeping. I've done that when I was there. So, please ask. More interaction, more learning. Just remember that. Now, again, assessment of the opposite truth. See here, this is my mistake. I have done that in my initial phase. I didn't check the position of the upper arch. So we just placed the implant, everything was ready. Second stage, when the patient came for second stage, we saw that there is absolutely no space for the crowns. So what we had to do was chop off the opposite ones. When you chop off means you have to do a root canal, intentional root canal. And when we do a root canal, we all know we are reducing the life of the tooth. Agreed? So now if the patient is not informed in the beginning, in the initial stage when he came for consultation, and I missed out on that bite, so now if I tell him that you have to undergo this and another additional 2 crowns and 2 root canals, it's an extra financial burden on him. Or sometimes they think that we are trying to fleece them. So now, where do you make the mistake? Intraoral examination. Okay. So, but we had to do it. So we chopped off, did an intentional root canal, and then replaced this. Then these were replaced by the general dentist. Then adjacent tooth assessment. What if you don't have a good contact point? What will happen? What will happen after rehabilitation? Frequent food impaction. What will happen if there is frequent food impaction? Periodontal issues. Periodontal issue means peri-implantitis. Peri-implantitis will lead to failure of the implant eventually. So very important that you have to check. Now this is still acceptable. There is a good contact here. But what happens if we try and place an implant here? First of all, it will not be an ideal size of the prosthesis of the crown. So either you can do 2 things or 3. First, refuse. That we cannot do. Second, we have to extract this tooth. If he doesn't agree to it, third is, again, do an intentional root canal, chop it off straight, give a crown. Still, you will not be able to give him a good molar crown. So the best option is extraction in these cases. Then, again, same, supra-eruption of the opposite tooth here, you have to. Otherwise, your crown, if you don't treat this and leave it, you can still give a molar crown here. But what will happen? The contact point will go down. So there will be a step from premolar down here. So there will always be a step. When there is a step, you do not have a good contact between 2. Again, same. Food impaction, peri-implantitis, eventually. Repeated visits of that patient to your clinic. Yeah? So adjacent tooth assessment or opposite tooth assessment is very, very important. Bite, again same thing related to that. Bite and occlusion, both dynamic and static. Means when the patient is chewing and when he's biting. Hard and soft tissue. When there is when there is deficient hard tissue, you have to augment. That's a fact. What if you don't do it and you try and place the implant and just do some particulate graft over it? It never takes up. We've seen it so many times. You raise the flap, there is very thin bone, you place your implant and you see that half of your implant on the buccal side is exposed. So what you do is take some particulate graft and put it over it and then suture. Will it stay? No. Even if it stays, it will be only 50% of it. It's particulate. It's not solid. If you not reinforced it with a titanium mesh or even with your membranes, it will not stay. unless it is reinforced with some rigid material like a titanium mesh, or you give a block bone. So all in all, I don't want to take you to that advanced level. So all in all, if there is not enough bone, first augment the bone. Augment the bone. Slight exposure of the implant on the buccal side is acceptable, but too much of it you have to, because you end up this kind of defect in the second stage. Okay. Same presence or absence of clinical of local disease or any pathologies around that implant, it has to be treated. If it is in the site of your implant, you have to treat and graft. If it is on the adjacent tooth, you have to treat that tooth, whether you do a root canal or a mycoectomy or whatever the treatment is required. Why it is necessary? Otherwise, many a times they are absolutely symptomless. They keep increasing and they will spoil your bone around the implant. They eat up the bone around your implant. So that is why it is must that you treat the adjacent pathologies, identify and treat the adjacent pathologies also. Another mistake. We check the bite, we have to check the mouth opening also. So there's this doctor who doesn't do implants. It's only the diagnosis, and then I go there into the implants. So during that diagnosis phase, he checked the mouth opening also. He didn't measure it, but he checked. He says it's decent. How he checked? He used to take the air rotor with the burr inside. If he's able to reach that area vertically with the air rotor, means the mouth opening is sufficient to place the implant. Remember, the implant drills are much, much longer than your diamond burrs. What will happen if there is not enough mouth opening and you try and place your implant? To accommodate, what you do is, you bend your handpiece. So will you be able to maintain the proper angulation or inclination of your drilling and eventually your implant? No. So your implant will be either buccally tilted or mesially tilted, because that's how you are trying to adjust your handpiece. So you end up placing a wrong angled implant where it will not have axial forces. You must have learned yesterday in your basic implantology. Your implant should have axial forces on it, so that there is no bone loss around the crest of your implant. So if we have placed an implant like this and the forces are, axial forces are not there, it's inclined forces, you will have bone loss around that implant. So this is so important in the initial phase to check if you will be able to, your instrumentation is comfortable. Clear? Not even a simple question. Okay, then next comes investigation, routine investigation, and then special hemogram in case of people who have history of diabetes. Glycosylated hemoglobin is the most reliable. Why? If patient knows that, let's say this coming Saturday, I'm getting the implants done, and doctor has told me to get the sugar test done on Friday, what will he do? He'll control his diet starting Wednesday. Thursday or Friday. Friday when he gives the sample, what will be the sugar levels? Normal. I see the report, I said very good. Normal sugar levels, go ahead. 2 days of restriction after implant placement. Third day again he'll start poor for the second stage. Either he'll have severe bone loss or loss of phosphate integration or no integration at all. So what does glycosylated hemoglobin or HbA1c, what does it do? It will give you an average of how many months? 3 months. Why 3 months? I'm asking. RBCs are attached to the molecule 3. So it will give you, the patient can through this diet. So it will give us the idea whether it's under control or not. Acceptable HbA1c level for an implant or for that matter any minor oral surgery is higher side, 6.5 to 7. is acceptable. Anything beyond 7, no. Then investigations, radiographs, IOPA, OPG, occlusion, whatever is required depending on the tooth you are replacing. Impression is good. It's very good. It will help you till the end, till your second stage. So it is a very good idea to take impressions the day patient says, yes, I want implant. Wax up, prosthetic simulation. One, you will do a wax up the way I showed you that. You'll do a wax up and show it to the patient. It gives confidence and then good patient acceptance also. Secondly, it will help you in placing the implant. You can convert this into a guide. Again, it will come in the lecture, I'll show you how. You can even convert the patient's existing dentures into guide and place the implants. And they do make a difference. It is not about experience. If I am in a hurry, after 20 years of practice, even I am in a hurry, and if I don't pay attention to the angulations, I have made blunders, I have made mistakes. Nobody is perfect. The guide is always a good idea, whenever possible. It's always, at least when you're starting your implant practice, always use a guide. It's not always through a CDCT. There are chair-side guides also, how to make a chair-side guide. It's very easy. Next is ridge mapping. I've included this point especially because when we started practicing, there were no CDCT. If for an elaborate case of Leaford 1 osteotomy along with implants, those elaborated cases, we used to get a medical CT done. But the medical CT results, the films are not very clear. And they are very small. The slices are 1.5 or 1.75 thickness. Whereas nowadays what we do is 0.25 to 0.5 CDCT, and it is more clear. So earlier we had help of only ridge mapping. You all know what is ridge mapping? Can we have a board and some? Sorry, if it's okay. So, okay, so you have to. You've taken a OPG. You have missing posteriors, bilateral. Make a model, make a cast. Now, this is your area where you want to see how much is the bone and how much is the soft tissue. It is really sometimes very misleading. I'll share a small thing. So there was this guy who came, he was an African. So you know how big they have, big mouths, big jaws, everything. He had both molars missing, maxilla. Happy. We took an X-ray, sinus was way above. Usually in the kit, 5 mm is the maximum diameter of implant. Company always have additional diameters also on demand. So we ordered 6 mm. It was so big, so thick, 6 mm implant so that we can give him a big molar. When we incised, we opened up, we ended up placing 2 3.5 mm implant for a molar. Why? The thickness, what we could palpate intraorally was all thick mucosa. The bone was so thin inside. So now when the patient comes to you, you use both your fingers by general palpation and you see it is good. Maybe it is just hyperkeratinized mucosa only. The bone, underlying bone is very thin. So how to do that without having a support of CBCT? So now you have a model here. You cut the cast through and through into 2 pieces. Finally cut the cast into 2 pieces. Now what you have is thickness of the annulus with the soft tissue. Okay. Anesthetize on the patient, just anesthetize, or sometimes even the topical spray is good enough. Take your reamers, put a stopper there and insert at different places. 3 or 4 places for one side. So insert over here and put the stopper on the soft tissue. Now when you take out the reamer, how much of the reamer is beyond the stopper is the amount of cut cast in the same area, corresponding area, and just mark there. So in the end, what you'll have, cast mein, you'll have small dots, 4 or 5. Join them. Now you have bone which is inside, soft tissue which is outside. Understood or no? I know diagram would have made more sense. Understood? So that's called as ridge mapping. Same way, you go to the other side, cut the cast, do the same thing in the patient's mouth, and transfer it to the cast. So just draw a line, it will give you the thickness of soft tissue and the thickness of underlying bone. Clear? Okay. So chief complaint, investigation, diagnosis, everything is done. What should be your selection criteria for case selection? Just done this. Okay. I missed out a slide. So criteria for case selection, patient motivation and awareness level. You will see patients with filthy teeth, with poor oral hygiene, grade 3 mobility. They come and say, they have money. So they'll come and say, I want replacement. I'm busy, I don't have time. I just pull them out, give me good. I know the techniques. I'll also place the implant and give him a full mouth rehab. Within 2-3 days, he has all the teeth back which are firm and he's able to have his food nicely. But where have I made a mistake? I have not taught him how to maintain the hygiene. So motivation was not there. His motivation was so that he's able to chew nicely. But I have not educated him to maintain oral hygiene. Now I see that patient after 4 years, because implants have started moving. There is half a kg of calculus covering that, the processes I gave him. So whose mistake is that? Mine. Patient doesn't know. Patient thinks that if he can give me, it's okay, I have money. If these fail, again they'll give it to me. But every time we do a procedure, we lose a little bit of bone. Every time there is an implant failure, you lose bone. So finally, the day I say, no, I cannot do it, patient will pounce on you. So I have made the mistake because I have given the implants to a patient who's not very well motivated for oral hygiene. So first mistake. Then availability of hard and soft tissue. We've discussed that. Systemic background of the patient. Availability of skill sets. What do you mean by availability of skill sets? Today, once we finished the lecture and everything, so it was day 2, you have quite a good idea of how to place an implant. Yes or no? Okay. And tomorrow, if you have a case, believe me, placing implant is not at all difficult. If you can do a firm extraction, you can easily do an implant. It is just a mental block. It is very easy. Only thing is, you should know how to place an implant, the angulation and everything, which will be taught in your hands-on. So, if you place an implant, you will have basic knowledge and everything, and you end up placing. What if the patient comes, there is inferior alveolar nerve here, there is sinus which is pneumatized, you don't have enough bone, and so what do? You were not taught sinus lift procedures, you were not taught nerve lateralization procedures. So what do? Will you refuse the patient? You know, that's what availability of skill sets. If no import means you can call up any prosthodontist or any specialty, oral surgeons or periodontists who do all these procedures. So availability of skill should not be a blockage in your practice. If you don't know how to do it, don't feel shy, and I'm not at all shy to say, in my life, I've never done a although we were taught during our graduation days. But we've never done it. Because I never tried, I never had that confidence. Till today, I have never done a root canal. The only root canal I've done when we are doing an episectomy where I can see both the ends and I'm sure that I pull the gutta percha from the apex and then seal it. That's the only time we do root canals. Okay. So never ever feel ashamed or shy to say, no, I don't know this. You can. You have specialists everywhere. Affordability of the patient, very important. Give him the whole treatment plan. You never know when you're doing the procedure whether you require a grafting procedure along with that, or you require an angulated abutment which costs extra, or would require screw retained prosthesis which again costs extra. When you ask the patient and he says, no, you told me X amount, now you're saying X plus Y, why this? So you have to see the affordability, give him the whole thing, the expenses. If you're not able to predict whether your expenses will be more, say that this is it, and maybe you'll have to add some more that will decide in the second stage. So your motivation can be good, average or poor. Your available, systemic background, age, considering the age, medical illness. This you must have discussed yesterday in your basics. So I'll just run through. Okay, diagnosis. Now comes the treatment plan. What should come first? Don't look at the diagram. What should come first? Prosthetic treatment plan or the surgical treatment plan? Prosthetic. Why? See, here in Indian practice, most of us are doing both surgical as well as the prosthetic part for any implant. But I know there are places, I don't do much of prosthetic, I do quite a bit, I don't do much of prosthetic. Elaborated prosthetic procedures are done by a prosthetist. So if I am placing an implant, I don't know how the prosthesis will be. So first, you have to, in case second stage is done by a prosthetist, sit with him, discuss what does he want, where the implants to be placed, what angulation, what should be the level of implant, should be subcrestal, crestal or supracrestal. The type of implant you are using, whether they have a polished collar or they are fully treated, all those things should be considered and make a prosthetic plan. Whether you're giving him a bridge or you're giving him a hybrid, so all that has to be considered first, and accordingly you do your surgical planning and then place your implants. After your surgical planning, in case there is deficiency of bone, you have to alter the bone, augment the bone, sometimes reduce the bone, or else you straightway place your implants. So level of oral care. Then patient motivation, expectation, all that. Few diagrams and a few things I want to show you. This is purely for your practice. If this is the kind of patient who comes to you and asks for implant, will you straight away do implants? No. If there is natural dentition has failed, implants will fail even early. No? The osteointegration is delicate than your the periodontal fibers. So it will definitely fail. Now, how are these patients described? They seek treatment on emergency occasions only. If this is the kind of patient, I think your alarm bells should ring. Then usually family and friends have pushed him for. Wife will call up and take an appointment. That husband will come today, he's busy, his office ends at 6, he'll come at 7, this, that. So these are kind of patients who are ignorant about their oral health. Amateurs at the dental office, very good sign. You ask the patient to sit, he'll sit on the operator's stool. So that means he is not been to dentist very often. Now you ask the patient to spit, he'll say into this. Or he'll search for water. All those things should make you understand that he's not very comfortable with dentists, or he's not been to any dentist many times. So all these points. Last point is very important. Again, same. Till now, you are in college, and whatever you charge from the patient is very reasonable. It doesn't pinch to the patient, or the patients who come for treatment are very well informed that they'll be charged so much. Now, these kind of patients, in your practice, when you tell them, okay, this amount, 40, 50, whatever your charges are for an implant, 50,000. You know what my first patient told me? My cesarean was less expensive than your dental implant. So these patients will definitely get a shock when you tell them, these kind of patients, because they have never been to a dentist. Second are average. They'll understand, they'll come only when their treatment is, when there is pain, they'll come for straightaway root canal, they'll never come for fillings. The simple answer is, I didn't have any pain, so I didn't come. I said, do you wait for your car to stop and then take him for a service? Or you take your car service for every 6 months or 5,000 kilometers? This is the example we have to give them. History. All these are points for an average. I'll just skip it. So, now timing of placement of an implant or a tooth. First is immediate, early and delayed. There are 3 kinds. You all know? Yes or no? So what are immediate? Let's say, for example, when the patient comes after a trauma. He or she is lost. Most of the time it is the anterior tooth. So this is the condition. Both front teeth were fractured. So we planned for a root canal in one of them, and then the other one was extracted. The extraction for an immediate placement implant, or otherwise also, whenever you're planning, even a delayed implant, should be atraumatic. Should be atraumatic, absolutely atraumatic. So there are times when we spend 45 minutes to 1 hour for an extraction, another 10 minutes to place an implant. Agree? No? People who are already doing implants will agree to it, because it has to be absolutely atraumatic, especially the buccal plate. You remember, what were you taught in your 3rd year when you started oral surgery extractions? How to extract the tooth. You hold the tooth, and then what you do is buccal movement, come back, buccal movement, come back. So why buccal movement? Why not palatal or lingual? Because the palatal plate is strong, the lingual plate is strong. The weakest part is the buccal plate or the lingual plate. So now, and we use the term expansion of the socket. But what are we doing? We are out fracturing the buccal plate. Whenever there is buccal plate fracture, you will lose bone. So that's what I mean by atraumatic extraction. First of all, no buccal bed. If it is a root stem, it has to be extracted using your periotomes or Coupland elevators. No forceps used. Or if it is a whole tooth, and let's say if it's a molar, sectioned molar, convert it into 2 single rooted teeth and then take it out. There should not be any buccal movement. The moment you do a buccal movement and you out fractured the buccal plate, you will lose it. Within the first 4 to 6 weeks, you will lose that bone up to 40 to 50%. It's not my observations. It is there in the articles. So no, it has to be atraumatic. Then place your implant. Another point, it cannot engage your labial plate. Can you see here? There is a big space between your labial plate and the implant. Why? The moment your drill or the implant, if it engages the labial plate, there is trauma to it. And how thin is the labial plate? You can see in this picture. And this is a decent one. Because periodontally healthy, this is a trauma patient. This is not a periodontally compromised patient. Most of the time, the patient comes to you is a periodontally compromised patient. There you extract and then place an implant. This is a trauma healthy young patient. Still, how thin it is. Okay. So you have to, the moment your drill or your implant engages the labial plate, there is something called as bone dieback. What is bone dieback? Bone dieback is whenever you are doing an osteotomy, when you are preparing your implant osteotomy, in spite of using sharp drills, in spite of using copious cold irrigation, in spite of limiting your torque and the speed of your drill, still you will cause trauma to the bone. So what does that happen? What are the signs? The bone undergoes resorption. When you take an X-ray, you will see a thin radiolucent line between bone and the implant. Yes or no? But physical bone is still there. When I say bone dieback means there is demineralization of the bone. Okay. Only the mineral content of the bone is lost because that is the most sensitive content of the bone. And any trauma or the heat caused by the drilling, you will lose that mineral content of the bone. But it will always come back. Why? Because there is healthy bone behind it. And how much is that? How much is the bone dieback? Means how much of bone will demineralize? It's 0.8 to 1.5 mm worst condition or 1.2 mm. Usually it is if all the conditions are favorable. As I said, irrigation, sharp drill, speed, everything is okay. It is 0.8 to let's say 1 mm. Now how much of the bone is there? 1 mm? No, maybe 1.2. Now if I drill on this labial bone, the bone undergoes demineralization or there is bone dieback. Is there any healthy bone to give a supply of your new cells, bone cells? No. So what will happen? The bone gets eliminated. That's when the patient comes for second stage and you can see the threads through the buccal mucosa. Because the implant may be stable, but aesthetically not good, periodontally not good. The patient will keep coming to your clinic with complaints, pain here, tenderness, bleeding, all that. So that bone dieback is, you have to accept it, it will be there, but minimize it by following the ideal protocols. So again, say for the same reason, now you have bone on the mesial side, you have bone on the distal side, you have bone on the parietal or lingual side. So you are not too much worried. Mainly the labial plate. So your implant placement should be away from the labial plate. The newer protocols from ITI is the body who regulate all the protocols all over the world. So ITI says any extraction immediate implant should be grafted on the labial aspect. Whether there is gap or not, or enough gap, or you can even augment the bone on the labial aspect, reflect the mucoperiosteum and place the bone graft there. That kind of bone graft will stay because one, you are raising a healthy mucoperiosteum. That's not the extraction site. You are raising it from the labial plate. And there is solid bone beneath. Morning I told you that you cannot graft on the buccal, on the exposed implant. It will not take up. But since you are grafting the side over the bone and in between the bone and the implant, so there is support from it. And always raise the mucoperiosteum clean, one piece. If there are any lacerations or if your periosteum is torn, again the healing will be compromised. Why healing will be compromised? But what lies above the periosteum is mucosa. Mucosa is formed by fibroblast. No? What we want over there is osteoblast because we want bone to be formed. But fibroblasts are more quick to form. So they will come, evaginate into the space where the bone should be formed. And finally, what you will have is fibro-osseous integration rather than osseous integration. Or if it is a grafting site, what will you have is a soft bone, which will resolve easily. Clear? So, graft the site, suture. Second stage, and this is the final outcome. So, from here to here. So, this is immediate. Again, criteria: exclude pre-existing pathologies, optimal recipient bone. If the bone is not there, never do an immediate extraction implant. Just graft that site, leave it, and recall the patient after the bone healing phase. You have modified surgical protocols. This is a different topic in itself, the immediate extraction plan. So just briefly, I'll tell you a few points. Modified prosthetic protocols. Second is early. What do you mean by early? How early? After extraction. If not at extraction, then how early? It's there. 4 to 8 weeks. Why 4 to 8 weeks? Osteoblastic or osteoclastic? Anyone can explain me the steps in a healing socket? Third year. You all are final year or final year? So third year when you were taught. So what happens in the first week? What happens in 2 to 4 weeks? What happens after 8 weeks? Why I say 8 weeks? Okay, simple. The osteoclastic activity is over. The maturation phase begins. So although at this stage when you are placing your implant, there will be soft bone. You will not have a good primary stability during this phase. You may not have good primary stability. But still you will be able to place your implant and then wait. You cannot load these implants immediately. You place your implant and wait. If we wait for another 8 weeks or 10 weeks or 12 weeks depending on the site, your bone healing will be 8 weeks plus another 8 weeks, 16 weeks, which is like a mature bone, 16 weeks old. Okay, so that is why 8 weeks. The only point is the pre-osteoclastic activity and osteoclastic activity, both they start at 7 days and they get over at 8 to 10 weeks. So again, this lost the tooth, placed the implant, got good primary stability. This shows there is around 35-40 Newton primary stability, good primary stability, grafted and sutured, and this is at the second stage. So the only good advantage of two-stage procedure is you end up having a very good soft tissue, quality-wise. But the disadvantage of waiting and then doing a two-stage procedure, you don't get quantity of tissue. You lose the interdental papillae, you lose the architecture of your soft tissue, all that is lost. But the quality of soft tissue is good. So here if you see, we still have a good architecture but not as good. This arch should have been compared with your labial architecture of your right side, 1-1. This is 2-1. So now when we place the crown, see where the labial margin is and see where the labial margin of your existing. So this is maintained when you are doing an immediate extraction and immediate loading. So bone and soft tissue are optimal. Standard implant procedure, advanced procedures, not necessarily single stage treatment plan possible, minimal risk of delayed healing. All these are pros. Prosthetics are uncomplicated, excellent long-term predictability. Now, delayed is what? I have not put any months in. What is delayed? Louder. What is that maturation time? Is it same for all the areas? Is it same for both the jaws? No. Why different for both the jaws? Anyone person. Why different for both the jaws? Okay, osseointegration period is same for both the jaws? No, why? More porous, yes. So that's a problem in your primary stability. More porous meaning more bone, more blood. No, more porous is more blood. So there should be early osseointegration, but we wait longer period for maxilla. You know D1, D2, D3, D4 bone, which is good. D2, D3. D1 is not good. Why? Because it is pure cortical, dry bone. There is no blood in it. It is good for primary stability, but not good for osseointegration. That's all. I'm giving you hints. It is porous because there is reduced BIC, bone implant contact. If there is porous bone, so there is more amount of what do you call that? Interlocular space? No. Intertrabecular spaces. So you have trabeculae in the bone, so that trabeculae are sparse, big ones. So that when you place your implant, how much of bone comes in contact with your implant is your BIC, bone implant contact, which is more in a dense bone like mandible or anterior maxilla, less in your less dense bone, more porous bone, which is your posterior maxilla or posterior maxilla basically. Okay. So that is why healing also takes long. Healing also takes long because of the maturation of the bone, because of less supply of bone during bone formation, during your new bone formation. So that is the reason we wait. After extraction, if it is mandible, we can place the implant after 8 weeks, 10 weeks and get good stability. Whereas maxilla, if we wait and place an implant after 8 weeks, it will be very soft bone. It's not that it is contraindicated. We can still place it, but we can alter our osteotomy procedures. That we will talk once we are onto that. Implant placement steps, which we implant placement steps we'll be doing today. We'll be doing it today or it's done? Today we'll be doing it. Okay. Let me just finish this one in 2 minutes. Okay, no, this will go long. We'll wait for it.
You all can wait 15 minutes.